Good morning, everyone. Hopefully you guys have a good day so far. So again, I'll introduce myself again. اسمي عبد الرحمن حسين العدن. Currently, I'm the General Manager of the Ambulatory Services inside Red Crescent. So basically what this long title means, basically we are supervisors of quality and medical services on the field. So when I was asked to do this presentation, and by the way, I want to thank the organizers for giving me this opportunity and pleasure to do so, and it's a great honor for me myself personally and for the South Red Crescent. When I was asked to demonstrate the challenges for implementing a perfect EMS system in Saudi Arabia, I decided not to delve into the philosophical realm of what is perfection, but kind of get into it from a functioning definition of lack of problems or being flawless as much as you could. Now, this goal is unattainable, but that does not deter us from trying to attain that goal. So I decided to kind of categorize the problems we face, and I'll just add a little bit of a caveat, which is this is peculiar to the Saudi Red Crescent. I'm not speaking generally about Red Crescents or Red Crosses University. So bear in mind this is homemade, so to speak, and custom to our needs in Saudi Arabia. So the categories I kind of mentioned are not really encompassing that much, but I do feel that kind of give a good overview of what we face as administrators and as leaders in the Saudi Red Crescent. So before getting into it, I'm just going to give you a quick overview and a quick history of Saudi Red Crescent. So introduction, we are part of the International Federation of Red Cross and Red Crescent Societies. Saudi Red Crescent, which I'll be referring to as SARCA, is the main provider of EMS in the Kingdom of Saudi Arabia. 24/7, so no days off, no holidays, nothing. So there we go. So brief history, we're a charitable ambulance society, Jamaica Al Khairiyya. Then we kind of advanced into being the Saudi Red Crescent Society, Jamaica Hilal Ahmar, and as of late, we have been the Saudi Red Crescent Authority, Hayat Hilal Ahmar. So generally, I'm just going to talk about what we have currently. So we're close to 10,000 employees, both field workers, as well as administrators in the main offices. Currently, we have 7 air bases across the kingdom that offer aviation medical services. Now, just kind of a comment, currently it's suspended due to a lot of red tape, basically, but soon, hopefully before Hajj, we're going to have it up and running again. We are shy of 400 stations across the kingdom. So again, level of service, we have basic and advanced. Advanced units are manned by doctors or paramedics, and basic units are manned by EMTs, technicians. Again, we have ground and aviation. Ground, we have at any given time 400 units covering the kingdom 24/7, and 47 units of advanced life support covering the kingdom as well. Now, the advanced is at selected regions, not all regions, but hopefully we can get it to all of the regions of the kingdom. But as of late, as of recently, we've adopted about 12 or 13 regions. Air transportation or air services are only manned by advanced units. Again, doctors and EMTs. So this is generally a layout of the stations that we have and beside the Red Crescent. So this is basically what happens. So this is a generalization. So the caller calls 997 hotline. Okay, dispatch receives the call, gets the essential information, contacts the closest ambulance or the freest ambulance, gives the vital information, ambulance makes its way to the location of the patient. Now, at that point, either we treat the patient and the job is done, or we transfer the patient to the hospital. Now, to transfer the patient to the hospital, as my colleague just now mentioned, that further communication or prior communication has to be made. Availability, what kind of trauma we have, and then it's not the closest hospital, but it's the most appropriate hospital. If you're dealing with trauma, you don't put it to a hospital that doesn't deal with trauma. So the challenges. Again, I decided to put the categories as follows: geographical and logistical, manpower and human capital, and system. Now I'll just explain each one closely. So let's go with the geographical. So geographical location. So EMS service essentially is a response unit or a response service. But we have proclivities in SARCA to be perfect. We're not close to perfect, but we try to be. So being a response system or respond unit doesn't mean you just wait for the call when we head out. You kind of have to anticipate. So you have to do research, due diligence, discover patterns when you need ambulances. For example, rush hour, that's essential. Universities, when we have festivities, Janadriya, Haya, so you have thousands of people in one point. So all this kind of plays a role in providing the service. I just want to add a little point. Any measure of any emergency system does not change, which is the response time. The faster we arrive, the more chance or the potential we can save lives. So I'll just go ahead. Choosing the location efficiently is a crucial component in providing high-quality EMS. Therefore, when coming to a decision on the location of the station, we approach it from a very scientific and pragmatic point of view, i.e., not always do we get what we want, so we have to be pragmatic, second best. So a criteria of priorities attained from research and due diligence is taken under consideration when choosing the location. So basically, 3 categories or 3 criteria, which is number of calls around the area. The higher the number, the higher the demand. Population density. Higher number of people, the higher the potential. And also, part of the slide is missing. High-risk areas. Factories, power plants. Again, if stuff goes wrong, it's going to be chaos. Again, the issues and challenges present themselves when choosing the location. So, we do the studies, we do the due diligence, we contact, the authorities, we say, okay, this is the proper location that we want, this is going to serve our needs. Now, excuse me. So what kind of problems do we face after deciding the location? First of all, real estate is not available. Lack of funding, changing of landscape. So, I think the first 2 are self-explanatory, so I'll go to the changing of landscape. So, you choose the location, you get the funds, you establish a station, you have your employees. Now, somebody decides to do extensive road work that takes up 2-3 years. Kind of changes the whole dynamic. Another aspect to it, it's no longer densely populated. You got a lot of traffic, tomorrow no traffic at all. So kind of renders the whole station and studying null. So you start all over again. So that's one of the frustrations that we face. Now, taking such deterrents into account, a compromise has to be reached to provide the EMS service needed. Now, the problem is, any compromise in EMS or providing EMS quality kind of has a high price, which is human lives. So when you say a margin of error of 0.1%, that 0.1% is a human life. But again, we have to be pragmatic and kind of acquiesce to the needs as best we can. So the overall ramification of such a compromise does not affect the competency of our EMTs only, but they do affect the external factors such as response time, access points, strategic placements, and so on and so forth. The effect of overall EMS services provided is affected by such compromise. How little the compromise is or big doesn't really matter. It is a compromise, and some people do pay the price, sadly. So again, I kind of suggested the problems. I'm going to go ahead and suggest the solutions. Now, these solutions are currently what we're doing and what we plan to do. So, acquiring funds through their national transformation program, excuse me, collaboration and cooperation with upper government and non-governmental entities to help facilitate in acquiring the needed areas. For example, you got malls, you got universities. So malls are peculiar because you got from daytime till midnight, thousands of people in one location. Kind of helps us. Universities, daytime till mid-afternoon, kind of helps us as well. So we're planning to, or we are currently using this information as a way of providing the service. And the stations themselves can be portable or fixed. So when we have stations that are fixed, usually the studies show that it has to be permanent. But in malls, and as well as universities, not necessarily. Summer vacation, you no longer have that much of the students. So you can transfer the station and the manpower to somewhere useful. Okay? So this is kind of a disturbing number that I'm going to say, but we're here going to be stating facts and be as clear as possible. So the Red Crescent is required to provide the entire Kingdom of Saudi Arabia with its services. Excuse me. And although it's a great honor and privilege to do so, without current capabilities, we can only acquiesce the needs of 30 to 35% at best. Now, that's a low number. And so basically I'm saying that 70% of the demand we cannot meet. Now this is, I have an explanation to it, and it's not a justification, it's just an explanation. Recently, in the last, let's say, 12 years, the importance of the Saudi Red Crescent and its services has been demonstrated. Whether we're talking about Hajj, which I'm going to get to later, or just on site, on traffic jams as well. So the demand, which is justifiable, has been increased, but the problem is we can't meet that demand, again, due to our reasons, either manpower, which I mentioned, funding, and you can't have an ostensible, choice between quality and quantity, and dealing with human lives, you always have to go with quality. Am I right? That's what I believe so. So current operations as follows. As I've mentioned, we're shy of 400 stations throughout the kingdom. This is both urban and rural areas. Roughly, we have one ambulance unit servicing every 146,000 people of the populace, one ambulance crew situated every 246 kilometers. Oh, that's almost 20% along the rural areas of the city outskirts. So basically, you have an inner city like Riyadh or Dammam or Khubr. Then you have the rural areas, which is far off, basically not a lot of people, but still you have to provide service there. So while we try to best acquiesce to the increasing demands of EMS services, some negative effects are noted due to the limited resources, which is to be expected. So negative effects: diminished quality of services of EMS in terms of response time. Again, I have to emphasize response time is the only criteria that we look into when providing the EMS service, not taking into account the competency of the staff, but response time should be as low as possible and should make sense. For example, I can't have a city, a metropolis like Riyadh, response time which is 10 minutes, and a metropolis as well, I have a response time of 2 minutes, which is a similar situation, geographical landscape, and such. So response time, response time, response time. Not able to meet demands of our services in a satisfying manner. So this is a subjective term, satisfying manner. To whose satisfying manner? Which is to us. Basically, we want to get to the patient as quick as possible, assess the patient as best we could, provide the proper medications, provide the proper treatment, take the patient to the proper hospital. Sometimes, because of logistical problems, you're not able to do that. Again, this is not justification, I'm just telling you reasons. So again, I relayed some problems, and I'm going to see initiatives and actions taken to resolve these issues. So again, we have a large gamut of services that we provide, so we want to create more jobs. Now, not every field work is affected by field works alone, so you have to have proper leadership, administrations, quality control, people getting you the right equipment, the best equipment. So it's going to be team effort. That's what makes Hay'a different than Wizara, which is we have one single goal: patient at the site, taken to the best hospital quick as possible. Collaboration with MOH, Wizara al-Sahha, and utilizing their facilities. So we don't really look at it as being competitors as long as being complementary. So you have a lot of health stations, Jama'at Sahiyya. We use them. Let's use your ambulance as well. Let's collaborate. Let's unify the number as well, which I'm going to get to later on. Third, encouraging more volunteers. So this could be consultants, this could be medical students, residents, interns. The more the merrier. Help us, we help you. Focusing on educating the public in first aid essentials. So we say we're the first responders. Technically, no. The first responder is the person who calls you saying that we have a problem. So when we initiated the Prince Naif program, this teaches basic life support, which is housewives, elderly, and even children can do. Currently, we have an initiative to participate in the Ministry of Ministry of Education, to have that part of the curriculum. Now, students might hate us, okay, we have enough on our table, but this generally will save lives, okay? We plan also to having, this is a future plan, plan on having one ambulance crew for serving 50,000 people of the populace inside cities, as well as urban areas, as well as one ambulance crew for every 50 kilometers outside cities, rural areas as well. Now, the transformation program kind of helps us a lot because it kind of cuts off a lot of red tape and kind of helps us, get to the point quickly. So instead of taking 1 year, we take 1 month, 1 week, so on and so forth. Now, this is human capital and human manpower. So just bear with me if you will. Just want to give you a scenario. I want you guys to just imagine with me. So you're at the station and you get a call from dispatch. Station X, you're needed. You had a head-on collision, multiple casualties and trauma. So you rush, you get your stuff, you jump into the ambulance, and you go. Excuse me. So while you're going there, dispatch kind of gives you more information. Oh, it's 50 casualties, 25 casualties. So that daunting feeling kind of grows inside you. Okay, well, what am I getting into? So you see the traffic, and the traffic starts piling up. And again, butterflies got to get into your stomach. What have I got myself into? Now you see the number of people assembling around the accident site. Now you get to the accident site. Now, even though I do believe EMT work is for the elite, even the elite are human, and they're susceptible to, external factors. Now, you get to the site, a lot of people. You see blood, you see violence, you see death. Now, people look at you. First of all, some people look at you as being incompetent. What they're going to do? Some people look at you, okay, angel of mercy. This guy's going to provide treatment. And some look at you as the miracle man. Now, you get into the scene, you fight off the crowd. Please let me just get in. You get your stuff, you contact your friends. Your colleagues. You get the stuff, you try to work, and then you see a cell phone. You see a cell phone on your face, you see an entrance saying, oh, you're doing it wrong. And in some cases, and I don't blame them, but the relatives, when they have one of their family members decapitated, it kind of takes a little time to sink in. So what they do, they get a gun. Stop working on this guy, you work on my brother. I'm stating facts, not passing judgment. So one is dead, one is to be dying because of lack of crowd control. Now imagine this being your daily job. So you see this situation maybe once, twice a month. That kind of has a burden on it, has a price that you pay. Not a good way to start off the day, not a good way to earn your living, but somebody has to do it. So one could say that the line of service in the emergency field is not a job but a call, which I thoroughly agree with. The noble deeds of altruistic nature and service is inspirational and praiseworthy. But field work, as you may well know, is very taxing and demanding, both mentally and physically. The dangerous nature of the work itself, dealing with tragedy regularly, the hostile and seditious environment, all this comes with a heavy price and consequences. Now, most of you guys work in a hospital and you kind of have a sense of what I'm talking about. Just amplify that by 1,000 on the field, no security, no controlled environment, the environment controls you. So, I'll just give you an overview of what we have on our staff. So we have approximately 5%, and it's an increasing of the workforce, are incapacitated or debilitated due to physical injuries and stress-related psychological ailments. 9% of our field workers have more than 20 years experience in the field. That's a high number. Increasing number of casualties in the line of duty. Now, I don't have an exact percentage, but this number is increasing yearly, and to be honest, even monthly. Initiatives and actions taken to resolve this issue. Psychological support unit has been tasked to deal with the psychological ailments that afflict some of our field workers. Now, let me be clear about this. I'm not saying that we're dealing with clinically insane employees, no. But, dealing with this, post-traumatic stress disorder kind of has a price, as I mentioned before. So we anticipate that this is going to cause a problem, so we provide this service to help alleviate the pain and suffering of our EMT workers. I'm sorry I'm going to rush because of the time. Providing safety and cautionary guidelines in dealing with dangerous calls. Reinforcing the safety first policy. If it's not safe, don't engage. That's what we got. You contact the authorities, tell them it's not safe, they send this either police or whatever, and take care of it. Now, system shortcomings. So this is a nebulous term. I'm sorry, I couldn't find a term exactly to describe it, but basically what I mean is system flaws, loopholes that we may find inside SARCA and outside SARCA. Basically, abuse of services, requesting to transfer cold cases. Some hospitals fail to honor our official agreement by refusing to accept emergency cases. I'm not laying blame, but I'm saying this happens. You don't blame the hospitals. Beds are fully capacitated. Not enough staff. Makes sense. I've been in a hospital setting myself, so I kind of see both sides of the argument. Diverting calls. Head to one hospital, waste time to go to another hospital. Some rural areas have to adopt long shifts because of lack of manpower. Another problem with remote stations is infrastructure limitations. Radio signals, internet accessibilities. Now, living in the modern age, a lot of stuff that we do is accomplished by internet. So, we're outside, kind of makes it difficult to reach you. So, what do we have as initiatives? Prioritizing calls, critical to calls via CAT system, computer-aided dispatch. Basically, this is computer software that we use that kind of put priorities on the cases depending on the information we get. The guy has a flu, as opposed to a guy got into a roadside accident. Yeah, this is very obvious. Informing the public, 997 is a hotline for emergency cases only. Rotational work between urban and rural stations, effective communication with hospital administrations regarding the acceptance of cases. Sorry, just 1 second, I want to explain this really quick. Now, this system shortcoming is a government mandate. Basically, you have a mandate that says any person, any employee of any government body who is assigned a task that requires them to expand this distance of 75 kilometers in one shot, so from point A, point B, more than 75 kilometers, are eligible for a compensation into that. Now, I'm going to just mention workload disparities. So what you got is high number of calls, no 75 kilometers allowance inside the cities. Benefit, get skills as sharp as a samurai sword. Outside the cities, you do get the allowance, but dull skills because of the number of cases that you don't get. Another sad fact that I'm going to mention, which is no housing allowance for EMTs, no medical insurance, no car insurance. I know it's a surprise, but again, we're trying to be as clear as possible. All these shortcomings and loopholes negatively affect the morale of EMT workers and thusly the overall level of service we provide. Now, initiatives and actions taken to resolve and remedy these issues. We got requesting government mandate to provide SARCA employees with housing allowance, medical insurance, and ambulance insurance. Restriction and difficulties in accessing female establishment. That's another problem that we face. So, there's a royal decree stating that any government and non-government facility is to be accessed by SARCA without prior sanctioning, without prior guarantees. I'm sorry. So this is another problem we face. Reckless behavior of drivers. You've seen them. Ambulance is speeding, you have 5 cars behind them. Ambulance stop, 5 cars get into the ambulance. Now, delays response time and care in hostile and seditious environment, all of which are the outcome of such. Again, what are we doing to resolve these issues? Effective communications with female establishments to be more accommodating and respect the royal decree that has been issued. Issuing fines and citations for any reckless driver purposely affecting the ambulance. So if you're stuck in traffic, an ambulance behind you, we're not going to give you a citation. But if there's no traffic and you're stopping in front of us on purpose just to be funny, well, it's not funny any longer because you could be facing prison time, you could be facing citations. Raising public awareness through social media and other outlets. Crowd assembly is bad. Give the EMS opportunity to treat the patient, assess the site. Don't assemble. Don't take out your phone. We've seen enough tragedy on the internet. You can look at it on YouTube. You don't need to see it live. Just, you see them, let them do their job. Also, launching the Unified Emergency Number 911. This kind of, secondarily affects the EMS quality. 997, 998, 993. The list goes on and on. I want you to call one number, 991. Emergency, police, whatever. Now, the public in facing issues in dealing with SARCA. Basically, a study has been done in Jeddah showing that only 33% of the public know about the 997 hotline. Now, this falls on us But we have been diligently working on a media campaign to make sure that people know that 997 is the emergency hotline for us to call so we can provide you with the service. Thank you very much. Any questions you guys have? You can answer.
Thank you, Dr. Rahman. Next, we'll open the floor for questions.
Yes. Just a comment, having been involved in EMS for a very long time, I think what we have to realize is that we need to take EMTs, paramedics, and have a maturation of their careers. We should not expect them at age 60 to be picking up a 300-pound patient in the field. So one of the things I worked on for a period of time was moving them from the EMT role into hospital positions, nursing, radiology techs, that sort of thing. We prepared, or at least are trying to prepare for them, to understand that this is a young man's game, or a young woman's game. You can't do that at a certain age. The comedy routine is 60-year-old paramedics doing CPR, and they fall over and somebody's got to do CPR on them. And I think that we should expect that this kind of trauma, both psychological and physical, is going to happen. So we shouldn't let them be in those positions at that age.
Well said. Longevity in EMS is not something that we look for. And actually we're working on a government mandate which kind of subsides the 60-year-old paramedic by having the retirement age much less, or after 20 years or 15 years of service, you immediately transfer to a more managerial supervisor role. This is what we do, but this is internal arrangement. It's not a government mandate, but that's what we try to do as well. You don't want any 60-year-olds doing anything that 16-year-olds couldn't do. So.
Assalamu alaikum.
Alaikum salam.
My name is Sadiq Wazan, 15 medical student from Umm University. I think one of the most troubles that you find the EMS and the ambulances is traffic. So I was thinking if you can develop a system between the EMS and al-Murur that you can access the Isharat al-Murur.
Oh yeah.
So,
actually, this is a current project that we're working on. Not only accessing, having the traffic light immediately go green whenever an ambulance is there, but also having a specific lane and to be diligently guarded. No one can use it except EMS, and not EMS only. EMS with the sirens on with the case. Because this, sadly, I have to say, this has cost many lives because of this. I mean, traffic jams are part of a city, but it's not a problem that it could not be solved, with cooler heads prevailed and, we sit together, we can find it. And it's actually one of the priorities that currently we're working on to solve. So hopefully within the next few months you'll be seeing changes positively. So.
One more comment, please. Through the expanding evolution of social media, why don't you just develop an application for the emergency? So people can reach you easily, and you might add in a location service that sends the accurate location of the patient.
I'm beginning to wonder if you have them all inside SARCA. Actually, one of the apps that we're working on is caller location, which we currently have, by the way. So you call us, we know exactly where you are. But we want to kind of advance it, again, as you mentioned, through an application. So age, name, sex of patient, medical history if possible. Not only that, we've done an initiative in having a collective of data. So patient goes to Mustashfa Takhasusi, we get that data. What kind of medications is he allergic to, what kind of operations he had, what kind of medical history he has. So this is an initiative going on, actually, we're currently working on. The application itself, not only do we have the application, but we're currently working on having the blood type on the application. Any known allergens, paracetamol, Advil, Profium, all that kind of stuff. The number of files you have in hospitals. So instead of wasting time taking you to a private hospital, and you have, for example, Mustashfa Malik Fahad, I'll just take you to Mustashfa Malik Fahad. And also to add to that, we're trying to have the rotational on-call of the consultants. If I have a cardiac patient, I can see, okay, Mustashfa Takhasusi has Dr. Flan, so just go ahead, he's the on-call, I'll take him. and subside the emergency room immediately to the cath lab if need be. So this is what we're working on. Hopefully soon we'll see good benefits and good changes.
Thank you very much.
Thank you, doctor, for an
Hello,
excellent.
excuse me.
Okay.
Go ahead.
I'm a paramedic intern. Are you considering hiring female paramedics?
Oh yes. The issue, and I'll be very honest with you, is the scope of practice. Now, we are currently using female paramedics in training, in the training venture. But no, that's not enough. We want them to join the field. We want them to join their other colleagues in helping out. We use them as volunteers also in Hajj. The issue is the driving. So EMTs without driving is kind of a doctor without a stethoscope. So that's a government mandate we're working on, so we can kind of, and again, this is, to be honest with you, this is what we've reached so far. Not having women driving, but as a scope of practice. As a scope of practice, you're driving. So that's the only limitation we have.
Okay, you talked about improving a lot of stuff, but you never talked about improving the EMTs themselves. Because they lack a lot of skills, and they are not professionals, and that's costing a lot.
Well,
Don't you think you should focus more on training them?
first of all, not professional, I would take, I would take an object to that. I take umbrage to that because they are, first of all, certified. That's number one. Number two, the mistakes that would happen on the field are magnified and amplified because it's the field. You don't have a controlled environment. Number three, we do, actually. Kulliyat al-Inaya, Kulliyat al-Ma'arif, a lot of universities that we're working on to help train and develop the EMT skills. Not only that, we do have an actually dedicated department called Training and Training and Development. Yeah, that's the name of the department that addresses these issues. We have constant supervision on the field. Any lack of skill, immediately you're pulled off the field, put on an intensive course to address and remedy that fault that you have. Now, I'm not saying we're perfect, and your observation is at point, but in any situation, hospitals or non-hospitals, you do find the good and the bad, and sometimes the ugly as well. So,
Thank you so much for your answers. I think we're running a little bit out of time. A wonderful presentation. I would like to chat with you even more, but because of time restraints, we have to move to the second lecture. Having said that, he's going to be around. Anybody wants to ask any questions, get more information, just go ahead and ask any questions.
I'll be happy to, and hopefully you guys